Hi, my name is Jacqueline Garcia. I'm a clinical investigator at Dana-Farber Cancer Institute in Boston, Massachusetts in the US. And I have the question, how could venetoclax, the BCL2 oral selective inhibitor, how could venetoclax-based combinations improve outcome in higher risk MDS? At this year's EHA 2022 meeting, we did not present our phase 1b clinical trial, which was previously presented by me at ASH in 2019 and in 2021, or by Andy Way, who previously presented at EHA. But we do have an ongoing phase 1b trial that has completed accrual, which we did not yet report, and an ongoing phase 3 trial, the VERONA study, comparing azacitidine plus venetoclax versus azacitidine plus placebo for frontline higher risk MDS. In the meantime, while we wait for these really important studies to finish accrual, as we've previously demonstrated really great safety with the recommended phase 2 dose of 14 days of venetoclax at 400 milligrams every 28 days, and a really impressive efficacy signal with nearly 80% with objective responses, 35 to 40% with complete remissions, and a 100% survival 18 months for those in remission. While we wait for that to be validated in the phase 3 study, there have been really tremendous ongoing efforts across the world with using venetoclax in MDS. As an example, at this year's ASH meeting, our colleagues at MD Anderson presented their own phase 1 data with combination venetoclax plus HMA therapy for patients with relapsed refractory disease or in frontline therapy. And what we have found really reassuring is that even though that's a single institution study, the results very much mimic what we're seeing in the multi-center phase 1b trial that has been previously presented, meaning that there is a high response rate of over 80% overall. Evidence of complete remissions, though they had a smaller number of patients, and good evidence for responses happening within the first 2 cycles. So I think that's really encouraging that at the same doses we're seeing across different clinical studies in MDS that are prospective, that there's similar efficacy with expected neutropenia and thrombocytopenia, no tumor lysis syndrome, and evidence of really fantastic efficacy. There was also data from the same group at MD Anderson looking at high-risk MDS relapsed refractory disease, meaning people who have lost response or not been responsive to hypomethylating agent, which is the standard of care for high-risk MDS. They describe in a very small cohort of patients for adults for adults using the same dose of 400 milligrams days 1 through 14. They demonstrate, again, safety with grade 3-4 cytopenias, no tumor lysis, and a response rate of 62%. Now, granted, this is among 13 patients, so super small study. They again demonstrated, similar to what we presented, Amr Zaiden presented last year and the year prior in the phase 1b relapse refractory study, AbbVie sponsored, that there was a low rate of complete remissions and primarily marrow responses or marrow complete remissions. And responses were appreciated across the mutational spectrum. In this MD Anderson effort, they saw that the survival was about 8.5 months and low mortality relative to this higher risk population, which was encouraging. MD Anderson also presented an update on their CMML population. And this is a study led by Sangeeta Venugopal. It's a phase 1/2 study at MD Anderson that looked at combining Aztec 727, which is the oral form of decitabine plus cedazuridine, in combination with venetoclax in CMML. They presented the first less than 10 patients at ASH and presented up to 15 this time around. So it was an extension of the same trial. Where they demonstrated no dose-limiting toxicities to date, no tumor lysis, a reasonable overall response rate of 87%. And among this very small population, they did see 3 patients achieve a complete remission. So it was a 20% CR rate and a 67% marrow CR rate. So not as high as I would have wanted to see for a study with this combination, given that it's higher risk MDS and CMML. We know that this disease population has been historically excluded from many higher risk MDS protocols because it is a different type of disease subset. But there has been really great preclinical data to demonstrate that the CMML population would benefit from BCL2 inhibition. And MD Anderson led that initial small study effort to demonstrate not only is there safety, but encouraging early activity. Whether or not this is the best therapy for CMML down the road, whether or not a triplet or something else needs to be considered remains to be seen. More mature data will be necessary to understand the meaning of using venetoclax and oral decitabine instead of aziridine in the CMML population in order to decide whether or not cytoreductive activity is meaningful and leading to an overall survival benefit or a decreased risk of transformation to AML. In the meantime, there was also presentation from the Curis group led by Guillermo Garcia Manero and Uwe Platzbecker, adding the IRAK4 FLT3 inhibitor emavusertib or CA4948 as monotherapy, but they did present that their next phase 1b efforts are to combine it with venetoclax. There has been a lot of attention placed on this IRAK4 inhibitor because the preclinical data strongly suggests there's activity in splicing mutated disease, specifically SF3B1, UTF1, and even in the FLT3 mutated cases, which the latter is rare in MDS. But as splicing mutations are prominent in MDS, we were really looking forward to seeing how rational combinations of this IRAK4 inhibitor could be performed and safely done in order to benefit more patients. So the doublet data, I do not believe was presented at this year's meeting, but the single agent data with the IRAK4 inhibitor was presented and the safety data looks encouraging. There was some early evidence and an initial hold for severe or grade 3 rhabdomyolysis and I think some protocol adjustments that were made thereafter to try to reduce that incidence, but otherwise the profile looks very encouraging. So at this year's ASH meeting, we're starting to see people think about the combination of HMA and venetoclax using different types of HMA therapy, oral versus IV. We're also seeing them use it in different disease subsets, not just MDS, but also in CMML. And we're starting to see some newer combinations with venetoclax because it's such a well-tolerated oral therapy and it can prime partner drugs, such as the one with IRAK4 inhibitor. And we're starting to see some early thoughts on triplet therapy for these disease populations, but that data is too immature at this time.